Most of the times, wherever I go, I discuss basics only. I don't want to do anything extraordinary. But what are the basics an ophthalmologist should know when he's seeing a corneal infiltrate? So as is mentioned in the books, should ask the history properly. So is it painful, or the intensity of the pain? How is it? Any discharge is there? How much is the redness? What's the duration? So these are the basic things. Most of the times we don't ask, just we see the infiltrate and try to go about it. But history taking is very, very important. And as I told you, when there is an infiltrate, what will happen to the vision? All those things you should predict and try to treat the cases. And how much duration is there? Is it a short time duration, or the duration is more? Then if the duration is more, then what could be the infiltrate? Is it an infective one? Is it a bacterial one or a fungal one? Like that you have to analyze and go about the case. And again, recurrent history. Is it there a recurrent attack? So what's the relevance of a recurrent attack? Is it the first attack or the recurrent attack? What's the relevance of that? So that's why, as the first speaker has mentioned, history taking is very, very important. And then you go about the examination and try to analyze the infiltrate. Then you think of the investigations which you would like to do. Then what are the, is it old case of any surgery has been done or previous surgery has been done? Because most of the times after surgery, most of the patients, they continue the drugs like that even after cataract surgery. So what will happen? So you should ask all these things, then you go about treating that case. So general condition also, and also the local examination is very, very important. What are the lead conditions, where the infiltrate can come, any mebomytis is there, all those things. These are all basics, which most of the times we lose it because we don't go into it. So if you, based on that, if you go about it, you can analyze your diagnosis and try to come to a conclusion, even if your microbiology support is not there. So the type of defect, where it is it inferior or superior, or any lag ophthalmos is there, all those things, these are all clinical acumen which develop slowly, and unless you have interest in analyzing a to treat a keratitis, it's not very easy. You just give drugs, a cocktail of drugs. No, you're supposed to think of it, see the local condition, see the recurrence rate. Is it a small infiltrate or a big infiltrate? What's the duration of the epithelial defect? All these things you take in history and try to analyze it. So when there is an epithelial defect, is it paracentral or inferior? Why I'm telling in all these things is, most of the times these are very important, and these are the basic things should be followed when you are seeing a keratitis case. And how about the edema? Is it epithelial or stromal or deep seated? So if it is edema is deep seated, most probably the infiltrated is deep, or it can be a viral origin. So whenever you analyze a finding, you are supposed to analyze it, try to analyze it, and try to come to a conclusion about the infective pathology that is lingering there. And depth, most important times is very depth. So if it is rapidly progressing one and is a deep one, if it's a gram negative one, it may perforate. So all these things you analyze very well. Then if the infiltrate is very dense, can I do a scraping on that, and where will I scrape? As the previous speaker has mentioned, that we have to go for the advancing edge or the base. And how do you scrape it? Single stroke, a unidirectional stroke, which blade is used? Everything is very, very important to take a scraping. And there is an indistinct margin, you try to go for the advancing edge, where you may get the infiltrate where the bacterial load is more. And if it is feathery and dry and discharge is less, long duration, then it may be fungal. So when you take proper history, then you take the scraping and try to go take the support of microbiology to come to the conclusion what type of infiltrate is lingering there. And as previous speaker told us about HSV, I don't want to go deep, but what are the manifestations? It may be epithelial, it can be stromal or endothelial. So infective keratitis, even disciform. So when you see an infective keratitis which is viral, whether you go for topical or steroid combination, all those things, you analyze the infiltrate. Is it a disciform or anything, whether to start steroid or not? So all those things you will be apprehensive. So you are supposed to be sure what to start. And is it a necrotizing one or an old one, whether it treats, is it a scar, is it quiet, will you start treatment or not? And whenever you are seeing a HSV case, you are supposed to see as a systemic infection. It's not a local infection, so it's a systemic infection, and unless you treat it properly with systemic medications, they may go in for post-herpetic neuralgia. So whenever you are seeing HZO, you are supposed to think on the lines this is a system disease, and you are supposed to treat it like a systemic disease, and what antivirals you will start, and if you start it within 72 hours only, it will be useful. So again, you may get pseudodendritic keratitis also. You should try to rule out, is it a pseudodendritic or a true dendritic? And also when there is uveitis, can it be a uveitis because of HSV? And as I told you, these are the long term durations where it has healed very well, and because of neurotropic mechanism, there will be a epithelial defect. Its own needs observation. You need not treat it actively, but you are supposed to give a supportive treatment so that the epithelial defect will heal. And nowadays we are seeing lot of cases and different type of keratitis. So sometimes you are seeing microsporidias also. So do you want any systemic treatment like deworming or anything? In microsporidias, you are supposed to think on those lines. And adenoviral has become quite common, and it is seeing lot of cases after conjunctivitis. You are seeing adenoviral. When to start steroid, how long you want to give steroid, how much time you want to give topical steroids, especially in adenoviral, which has become quite recurrent. Most of the times we are seeing recurrent adenoviral infiltrates. Acanthamoeba is quite rare, and when you have a system where the diagnostics to diagnose acanthamoeba keratitis is very tough, but it depends upon your clinical acumen, and the drug availability to treat acanthamoeba keratitis is very tough. PHMB, chlorhexidine is not available at your drug stores. You have to refer it to higher institutes. Thank you.
Thank you, Dr. Prasad. I think it's a very relevant discussion, because I think this is the third time during in the session where we are emphasizing that there is a very significant history taking that is important, and there is an importance of understanding each of the subtle signs. And also in Professor Malhotra's talk, HSV, again a very common disease, and yet it is primarily diagnosed clinically. So I think the message that goes from the discussion is that microbiology will be an ancillary. But now what we are seeing gradually is that it is the primary way in which we treat, and then we go back and revisit the ulcer. But I'm very sorry to say, even in tertiary places, having a good microbiology, especially ocular microbiology service, is a luxury. Not really a lot of people can have it. So the clinician is very much in the center of things, and I think each and every subtle sign, the history adds to one more point that helps us towards the diagnosis. Sorry for this rather long winding note, but I think we can have a discussion.
Just to summarize what sir is saying, there is a study in American Academy of Ophthalmology published, where they reviewed how many % of cases a clinician can predict accurately what is the cause of keratitis, and in that 70% physician, they could perfectly guess simply based on the clinical signs, whether it is bacterial or it is fungal or it may be some atypical organism. So trust your clinical skill and follow whatever sir just summarized in this basic presentations. If you remember those, you can easily diagnose microbial keratitis. Thank you, sir.